And thank you, Dr. Vilesh. So I'm audible, right? Yes. Okay. So the topic is tricks and tips on optimizing kidney perfusion during AKI to improve outcome. I'm just focusing on very easy to do, but often not followed simple things. If you properly do it, you can make a significant outcome in your AKI patient. So for all patients with AKI, if you want to have a good recovery of the kidney function, there are three principles or three pillars. Identify and treat the underlying cause. We have to ensure adequate kidney perfusion. That means optimizing the hemodynamics on the kidney and avoiding further nephrotoxic medications and insults. So here I'm focusing on how to ensure adequate kidney perfusion. It is very simple. It is very common sense to understand that if you want to ensure adequate kidney perfusion, we have to maintain adequate mean arterial pressure, and we have to avoid renal arteriolar constriction. Then only the kidney glomerulus will be perfused, and avoid renal vein congestion. If the venous system is congested, even if the blood is moving to the kidney with high pressure, it is not moving out. Still, the perfusion is affected. The last thing is something which we often overlook. So ensuring these 3 points, we can ensure an adequately perfused kidney during AKI, and we can get a good outcome. So first thing is on how to maintain adequate mean arterial pressure. The first thing I need to discuss is what is the adequate mean arterial pressure. By default, the default norm is that we are all taught to maintain a mean arterial pressure of more than 65 millimeters of mercury to ensure adequate organ perfusion and prevent organ failure in a setting of sepsis or in a setting of critical illness through fluid resuscitation and vasopressin. So the default norm is 65 millimeters of mercury. But let me tell you, we have to customize the mean arterial pressure target we keep for our patients with AKI. So one history which we should definitely take is whether this patient has a history of systemic hypertension and what was the previous BP recordings from the previous files or OP records sent. This is because the auto-regulation of the kidney, usually after 65 millimeters of mercury MAP, the organ perfusion will be maintained, and below 65, it will be coming down. So there is an auto-regulatory zone. This auto-regulatory graph shifts to right if there is a chronic hypertension. If there is a chronic hypertension, the 65 millimeters of mercury is not adequate for adequate kidney perfusion because it falls below the auto-regulatory zone. So if the patient having systemic hypertension, we have to keep a higher target. More was the baseline BP, and if the patient is chronically hypertensive, all the recordings is very high, please maintain a MAP of 70 or 75. So that is one thing which we often not followed, especially when the patient is ICU. We forget that the patient is having a chronic hypertension previously. And next thing is how to maintain adequate mean arterial pressure. Obviously, we all know that fluid resuscitation and fluids and vasopressin. But always remember that fluid resuscitation should come first. Without adequately filling the patient with fluid, if you go on with the vasopressor, say noradrenaline, so already the circulatory volume will be less and you are producing vasoconstriction, and the kidney perfusion will be actually coming down and it can worsen the AKI. So always fluid resuscitation, then on top of it, after resuscitation or along with the resuscitation, you can use the vasopressor. But don't forget fluid resuscitation. Next is how to assess the adequacy of the fluid resuscitation. You are giving fluid. How much is adequate? So is the resuscitation over? This is because only after fluid resuscitation we should go with the vasopressor. Otherwise, the kidneys will be affected. So how to assess the adequacy? So previously, everyone assessed the patient clinically. Then in early 2000s, after when the survival sepsis campaign studies were published, everyone started to use central venous catheters and assessing the CVP, which is very cumbersome procedure. Most often we cannot be doing. Now we have a very easy way. I will give a case. This is a 45-year-old post-renal transplantation. Baseline creatinine is 0.96. Patient presented with a fever of 2 days and chills of 2 days, and patient was anuric for 1 day. Patient is in hypertension, 80/50 millimeters of mercury, urea 190, creatinine 5.4, sodium 129, potassium 4.2. So this is an acute kidney injury. Clinically, it is sepsis, septic shock, and we have to intervene obviously cultures, antibiotics and all. So vasopressors or fluids. I just did an IVC assessment. In the screen, you can see the IVC. So there is a white line in the IVC, that is why I place the M mode, and below the screen, below the ultrasound, we can see a one-dimensional plotting of the IVC size with time, and you can see the IVC, both walls of the IVC are nicking. So IVC is fully collapsing. That means the patient is intravascular volume depleted. And even though the patient is anuric, BP is low, just fill the patient before doing dialysis or using vasopressors and all, because filling the patient is very, very essential. So I started to fill, and I monitored the patient, how it is being filled using IVC. And in 6 hours, I used 12 liters. It's on this, giving 12 liters of fluids, crystalloids, to an anuric patient in sepsis. It is a bit fearful. We should be very skeptical. We should keep in mind of the possibility of volume overload, pulmonary demand, all the complications. But I'm pretty sure that the patient is still intravascular volume depleted, because I keep on checking the IVC. And ultimately, in the right side of the screen, you can see a filled IVC. So in the left side, it is a collapsing IVC, and the right side, it is filled IVC. I'm pretty sure that no one will be able to give this much amount of fluid to this patient with a septic shock, who is anuric, without the help of a focus. With a clinical assessment and all, we will not have this confidence to give this much amount of. And ultimately, what happened? The kidney opened, started to pour urine, and AKI resolved. Patient didn't require hemodialysis. So that is the power of the focus and checking the IVC. And IVC assessment is very easy. We can have a echo probe or a curvilinear probe. We can just place it below the diffuse sternum, with the upper end slightly tilted upwards, so that we can see a visualization of the right atrium, and the probe should be slightly tilted to the right side, because the IVC is in the right, and left side it is the aorta. So probe in the midline, below the diffuse sternum, and slightly tilted upwards, and to the right we can see a beautiful image of the IVC. It is very easy. The learning curve is very less. And just measuring or looking at the IVC is not enough. We have to see the IVC collapsibility. This is because during the inspiration, the blood will be sucked into the heart because of the negative intrathoracic pressure. And during expression, the movement of the blood in the IVC to the heart is very less. So if the patient is volume depleted during the inspiration, IVC will be collapsing, and we can calculate the collapsibility index using an M mode. M mode is a mode in the ultrasound. Just press the M button and place the white line at the area where you want to take the measurement, and take the measurement at maximum measurement, minimum measurement. Maximum will be during expiration, minimum will be during inspiration. Maximum minus minimum divided by maximum is the collapsibility index. Always keep in mind that for a non-ventilated patient, it is collapsing, but if the patient is mechanically ventilated, it is distension, because the IVC distends during inspiration. So it alters. It is a ulta type. So we call it IVC distensibility index. And here we can see during inspiration, IVC is 9.9 mm, and expiration it is 15.4. 15.4 minus 9.9 divided by 15.4 is equals to 0.36. So 36% is the collapsibility index. And next simple thing, you can check or assess whether the patient requires more fluid during resuscitation is by carotid artery peak systolic velocity variation. Carotid artery is a very superficial artery. Just place a linear probe, the same probe which you use to place the IJV dialysis catheter. Just place it over the carotid artery, and just place the pulse wave Doppler signal, and you can get the velocity tracing. And what happens during inspiration, the blood will be sucked into the heart. And if the patient is volume depleted, the heart is getting only adequate blood during inspiration. The stroke volume will be more during inspiration. So peak systolic velocity will be more during inspiration. And during expiration, the peak systolic velocity will be less. So if you do a PSV variation, if the patient is volume depleted, you will get a big variation in the peak systolic velocity. The variation more than 14% means the patient will be fluid depleted, responsive, because the patient is fluid depleted and depends on the preload for adequate blood pressure or adequate stroke volume. So the PSV variation is just by calculating just in the plot, we can just plot the maximum velocity and minimum velocity. So maximum minus minimum divided by average velocity. That is maximum plus minimum divided by 2 into 100, we get a peak systolic velocity variation. If the variation is more than 14%, that means your patient requires more fluid. Please keep on doing the resuscitation, keep on giving fluids rather than going high with the vasopressin. And very important, we should always be using a dynamic assessment. So if you have a patient and if you want to check whether the patient is fluid responsive, you can use two ways. You can just give a bolus of 500 ml and see whether the BP is improving. Another way is keep the patient in 45-degree position and just place the linear probe on the carotid artery and check the PSV, peak systolic velocity variation. Say the variation is more than 14%. Then you make the, you don't make the patient supine and then do a passive leg rising. You will rise the leg to 45 degrees. You can see in the figure. So rising the leg has got venous system, which is a capacitance vessels, which have nearly 200 to 300 or even more amount of blood. So rising the leg acts as an auto bolus of the blood into the circulation. A 300 ml increase in the circulatory volume happens, and it results in the improvement of the BP. And immediately, if you see at the carotid artery, we can see the PSV, peak systolic velocity variation, coming down. So previously it may be say 16, and after raising the leg, it is only 8 or 9. That means the patient will be fluid responsive. So if you give more fluids, the patient's blood pressure will improve. So this is a dynamic assessment. And even if you don't have a focus and all, if the patient is having an arterial line and if the patient is mechanically ventilated, you can just see the arterial waveform tracing, and all the multipara monitors will give something called PPV, pulse pressure variability. It is just like the carotid peak systolic velocity variation. Similarly, the stroke volume will be more during inspiration because of all the blood is sucked into the heart, and during the expiration it is not like that. So the PSV variation can be used if the patient is mechanically ventilated. If the variation is more than 13%, the patient will benefit from more steroids and more fluid resuscitation. And while you're doing fluid resuscitation, say you're giving a lot of fluid. So in the previous case, I gave 12 liters of fluid in the first 6 hours. That to an anuric patient. And remember that the patient is in sepsis. Sepsis means there is a generalized capillary permeability, increase in the capillary permeability. The increase in the capillary permeability will be also seen in the lungs. So some amount of ARDS, very mild to severe ARDS, is very common in patients with sepsis. So if you give too much fluids, the pulmonary congestion can go high, and it can affect the oxygenation, and it can make patient it can lead to deterioration. So you can use a lung ultrasound. Lung ultrasound means just keeping the ultrasound probe between the rib space, and you can see B lines. The white line, the white horizontal line is the pleura, and from the pleura, multiple white spokes like things, ray like things are called B lines. B lines are the artifacts in the ultrasound produced by the lung water. So more and more is the B lines, more and more is the lung congestion. So you can every time you can just place the ultrasound probe and see whether the B lines are increasing, and if it is increasing, be very cautious or just be judicious on giving fluid. Restrictive fluid resuscitation will be like after every 200 ml, just reassess the patient and all is effective. And how to look? You can divide the chest into 4 regions: upper mid-clavicular line, lower mid-clavicular line, upper mid-axillary line, lower mid-axillary line. So we get an 8 areas. More than 4 B lines in these 8 areas means that there is a significant lung congestion. This is the imaging. The 8 zones total, there is a 12 B lines, so that is lung is congested. The advantage of the B line is B lines in the lung ultrasound can pick up lung congestion much better with better sensitivity than we pick up using crepitation using our normal stethoscope. So it is having a better sensitivity, picks up early lung congestion. So it is much better than chest auscultation. And many of the senior physicians and all can argue. So I till now use clinically to assess our patients. Why? Clinical assessment is still good. Why? I always prefer clinical than going into this focus and all. So one thing is, clinical means there is a lot of subjectivity involved. I'm not saying that focus is without subjectivity, but focus is more objective than clinical. So say how many logs are there. So one may be telling 3 and other will be telling 4. So a lot of subjectivity in clinical. For example, edema. A patient with septic shock or sepsis in your ICU. BP is very low. If you check, the patient may have edema. So if you go back clinically, I will tell the patient is having fluid excess, volume excess. Don't give much fluids. But keep in mind that in this edema could be because of hypoalbuminemia, and hypoalbuminemia is very common in sepsis because albumin is a negative acute phase reactant, and also there is an increased capillary permeability in sepsis, capillary leak that can also lead to low albumin levels. So because of the hypoalbuminemia, patients have edema, but in fact the intravascular volume will be depleted. If the patient is in septic shock, this patient should be resuscitated. So that is a fallacy if you look at the edema. And about the chest signs, crepitation. So if there is a significant crepitation, it could be lung congestion, and it could be also because of the ARDS, because ARDS is very common in sepsis. And even if there is an ARDS and there is crepitation in chest auscultation, patient may be intravascular volume depleted. So judicious resuscitation is still effective, still needed if the patient is in shock. And also ILD, COPD, lung atelectasis. Lung atelectasis is very common in the ICU patient. These all produces crepitation. So you will be misled. It all mislead you and avoid fluid resuscitation. It can lead to consequences of depletion and underperfusion to the kidney. So that is all regarding how to maintain the adequate intravascular volume, thereby maintaining the mean arterial pressure. And next is avoiding renal arteriolar constriction. If the renal arterioles are constricted, obviously kidneys will not get perfused. And after fluid resuscitation, we always rely on noradrenaline as the first choice of vasopressor. My question is whether the noradrenaline is kidney friendly or an enemy to the kidney. So the answer is noradrenaline given in sepsis, if it is a vasodilatory shock, it can increase in the mean arterial pressure and it can improve the kidney perfusion. It is a kidney protective. But if you go at a very high doses of noradrenaline, it can lead to renal afferent arteriolar constriction and it can compromise the kidney perfusion. So too high doses of the noradrenaline is not good for the kidney, but noradrenaline is still the first choice of the vasopressor when there is a vasodilatory shock at a reasonable doses. So if the doses are going high, rather than keeping on escalating the noradrenaline, one simple thing you can use is you can initiate on a vasopressin. If the vasopressin acts on the V1 receptor in a different mechanism, and it is not a very potent renal arteriolar constrictor like a noradrenaline, so it has got a synergistic action. So you don't have to keep on escalating the noradrenaline dose. And there are even some studies which combine noradrenaline versus vasopressin as the first line vasopressor, which is more kidney protective. And there is a marginal evidence that using vasopressin initially instead of noradrenaline can give a better renal outcome, but that is only for marginal data. So still now the standard practice and standard recommendations, guidelines and evidence is to use a noradrenaline, but at a very high dose, use a vasopressor. And if still if the BP is not maintaining, rather than keeping on escalating the noradrenaline, always rule out myocardial dysfunction in sepsis, because there is something called an entity. This is very, very common because of the septic cardiomyopathy. Septic cardiomyopathy is because a multifactorial, multiple causes, a myocardial depression happens. And in that case, whatever we are using more and more of vasoconstrictor, it causes more and more afterload to the heart, and it can lead to further myocardial dysfunction, cardiac failure, and the BP will not improve. So just use a point of care ultrasound, be having a portable echo done and see how the myocardium is behaving, how the walls are moving. And if you suspect a myocardial dysfunction, you can use a dobutamine on top of the noradrenaline. And always keep in mind that critical illness related corticosteroid insufficiency is very common. If the BP is not picking up with very high doses of noradrenaline, always start on a hydrocortisone, 200 milligram per day in as a continuous infusion over the 24 hours of 50 milligram IV Q6H, so that this corticosteroid insufficiency will be overcome and the BP will improve. So relying less on high doses of the noradrenaline is one factor. And another case regarding the kidney perfusion and vasoconstriction I need to tell is about a 65-year-old female. She is diabetic for 10 years, presented to the emergency with a lethargy, dizziness and cellulitis of the right leg. Patient is oliguric for 24 hours. Systolic BP is 70. So patient is in septic shock. Cause of sepsis is cellulitis. So from the emergency department, the patient was adequately resuscitated with fluids, started on a broad spectrum antibiotics, BP became normal in 2 hours. From the oliguria, urine output improved and urine started to come. So everyone became happy. And hope you can see the screen. This is how the trend. The day 0, day 1, creatinine is normal. Day 2, creatinine slightly increased. Day 3, creatinine is increasing. Day 4, day 5. Patient is clinically improving. Hemodynamic is stable. Overall status is improving. But by day 5, the blood urea is 148, creatinine is 2.6, and there is slight intake output mismatch, and there is a metabolic acidosis. pH is 7.2 and bicarbonate is 14. So what is happening to the patient? There is no nephrotoxic agent, no further BP fall. One thing everyone forgot, we got a consultation. One thing everyone forgot to look at the chloride level. The ABG will give the chloride level. Chloride level is 128. So this is hyperchloremia. So what happened is the patient was resuscitated with the fluids using a normal saline, and the patient's maintenance fluid was all normal saline. Normal saline has got equal amount of sodium and chlorine, 154 milliequivalents per liter sodium and chlorine. It led to hyperchloremia, metabolic acidosis, and hyperchloremia can also cause AKI, because hyperchloremia causes renal arteriolar constriction, and hyperchloremia causes the reduction in the strong ion gap and causes hyperchloremic metabolic acidosis. So you can see a different IV fluid. Always, if you are using a fluid resuscitation, always maintain a fluid which has got a difference between the sodium and the chlorine level. So normal saline, you can see it is 154, 154. Ringer lactate, the sodium is 130 and chlorine is 109. And if the plasma light A, it is 140 and 98. This 140 and 98 is almost matches how the plasma composition is. And there are a lot of animal studies which shows that the high chlorine produces a vasoconstriction because of the multiple mechanisms. That is also very true in our case. This patient has got a renal vasoconstriction that could be causing the acute kidney injury, and reduction in the strong ion gap, because there is a gap between the sodium and chlorine level. So sodium is a strong cation and chloride is a strong anion. And so total cations should be equal to total anions. So if you're giving a lot of normal saline, what happens? The sodium and chlorine level almost equal. The chloride level goes up. And this bicarbonate is a weak anion. It's a weak buffer. It is a buffer. That is why it is called a buffer. It is a weak anion. It combines with H plus and produces H2CO3 and all, and it gives a space for the chloride to rise. So reduction in the strong ion difference leads to hyperchloremic metabolic acidosis. That is why this patient develops acidosis. And what I give, I artificially recreated the gap by using an isotonic sodium bicarbonate infusion. It led to the reduction in the chloride level and the AKI resolved. And there's a study in 2018, there's a SMART trial, which showed that the balanced crystalloid, that is a ringer lactate or a plasma light A, is much better for the fluid resuscitation for ICU patients, because it leads to less requirement of the renal replacement therapy and less mortality in this group. And lastly, something which we all often neglect is avoiding renal vein congestion. You do a lot to improve the arterial BP, and you will be very happy seeing a very high BP recording in the monitor. It's over. Our job is over. That's what everyone will think. But giving a lot of fluid results in the venous site congestion, and it will be translated into the renal vein. And if the renal veins are congested, kidney cannot perfuse well, because the blood needs to go out of the kidney. So always assess how the renal veins are, especially after a large volume fluid resuscitation. So for this, the Vexus ultrasound is very useful, and it's simple also. The learning curve is a bit more than checking the IVC, but it is still simple. This is because in a filled venous system, the right atrial pressure will be transmitted to the organs. If the venous system is collapsed, so the right atrial pressure will not be transmitted into the organs. So we just look at how the Doppler signals in the vein, in the hepatic vein, portal vein, and the renal vein, and assess the waveforms. So this is how the hepatic venous flow. Just like the CVP, JVP, we look clinically. There is a lot of waveforms in the hepatic vein, S, V, D, and A. I'm not going into it. And you just place the ultrasound probe in the hepatic vein and see. Normally, if the normal venous flow, it will be predominantly negative. If it is a congested hepatic flow, because the IVC is full and congestion is going into the hepatic vein, if the liver is not draining properly, it will lead to a biphasic waveform. You can see S more than D. So a biphasic waveform means the hepatic vein is congested. Similarly, we can place the pulse wave Doppler arrow in the portal vein. Portal vein is very easy to identify. In this image, we can see the portal vein. The portal vein has got a white bright lining around it, and the portal vein, the flow is very smooth. If the portal vein is congested, it leads to a pulsatile flow, sawtooth-like pulsatile flow. And similarly, we can keep the pulse wave Doppler recording from the renal vein. It is very difficult to obtain renal vein. You just keep it on an artery. In the top of the graph, we get the arterial flow, and below we get a venous flow. Venous flow is a continuous flow. If the renal veins are congested, we get two discrete. If the mild to moderate congestion, and if the severe congestion, we get just one negative dip. You can just see the image how it looks. From the continuous to one discrete dips. If the renal veins are congested, that means your water is the fluids, so the kidney is not getting adequately perfused. Please avoid further fluid resuscitation, further fluids, and decongest the patient. You may start on a renal replacement therapy if the output is low, or you can start on a diuretics based on the situation. But avoid further positive fluid balance and try to decongest. Then only kidney get an opportunity to drain its whatever the blood is coming to it. And based on the vectors, we can grade it. You can just read about it. I'm not going into how to grade it. Just keep the ultrasound, record the Doppler signals from the hepatic vein, portal vein, and the renal vein. And so that is regarding how to ensuring adequate kidney perfusion. I just mentioned about maintaining adequate arterial pressure using fluid resuscitation, judicious use of the vasopressors, and avoiding excess renal arteriolar constriction by avoiding hyperchloremia. So we must be using less normal saline, because all the data is now more towards a balanced crystalloid, ringer lactate or a plasmalate A, rather than using a non-normal normal saline. Normal saline is not at all normal. It is just a two non-normal solution. And avoiding renal vein congestion, you can pick it up using vectors ultrasound. And if it is renal vein is congested, restrict the fluid and do all the needed, like a diuretic or a renal replacement therapy, and do ultrafiltration, make the way for the kidneys to drain the blood coming into it. So that's all. Thank you very much.